So subarachnoid hemorrhage is actually a hemorrhage inside the subarachnoid space that is most commonly due to trauma. Then second cause is aneurysm, and the third cause is arteriovenous malformation. Aneurysm may be associated with certain conditions like polycystic kidney disease, in which there are berry aneurysms that can rupture with increase in the blood pressure or straining. So how patient presents to you? The patient presents to you with sudden and severe onset of headache, and he claims that it is the worst headache of patient's life. He never experienced this type of headache. And GCS wise patient is normal mostly, but GCS can be down due to raised intracranial pressure and also due to ischemia, and ischemia is mostly due to vasospasm of the arterioles after subarachnoid hemorrhage. That's why we give nimodipine to the patients that prevents the vasospasms. Furthermore, patient can present with the features of irritation of the meninges, that is, the person presents like he is having meningitis, that is, person has neck stiffness, and positive Carnegie and positive Brudzinski sign can be there. If we want to diagnose subarachnoid hemorrhage, first we will do CT brain plane, but in most of the cases on the CT we can miss subarachnoid hemorrhage. So MRA, magnetic resonance angiography, or CT angiography of the brain should be done, and it shows the culprit vessels which lead to this subarachnoid hemorrhage. We should also do LP. LP is done to further confirm the subarachnoid hemorrhage. There is presence of RBCs in the LP samples, and to differentiate it from the traumatic LP, there should be no clearing of the RBCs from all the bottles of the LP. Furthermore, there is xanthochromia, and for xanthochromia to appear in the blood, there should be at least 2 hours. So if you are not sure that this is a subarachnoid hemorrhage, then from xanthochromia you can confirm that this is subarachnoid hemorrhage. Furthermore, if RBC count is less than 2000 per mcl, then it should be remembered that there are less chances of subarachnoid hemorrhage. Other thing is digital subtraction arteriography, that is also a gold standard investigation, and it is also helpful in to some neuroradiologists, interventional neuroradiologists, to close the Furthermore, you have to control the blood pressure, and the blood pressure should be less than 140 millimeters of Hg, and you have to treat vasospasm, and for this you have to give nimodipine 60 milligram every 4 hours for 21 days to all the patients of subarachnoid hemorrhage. Furthermore, if there is raised ICP due to blood in the subarachnoid space, you can have raised ICP, and for this rise in the ICP you have to put the shunt inside the ventricles. Sometimes patient develops cerebral salt wasting, and for this you have to monitor sodium, and when there is cerebral salt wasting, this cerebral salt wasting can lead to edema, raising further ICP. Therefore, if it happens, then you have to treat with hypertonic saline, so that this edema can be controlled and further deterioration in the GCS can be prevented. So this is all about subarachnoid hemorrhage.